the Rutgers Cancer Institute. And then on behalf of Screen and Jay and the Rutgers Cancer Institute, hello and welcome to Community Cares and Project Echo. Thank you for joining today's session, and we hope that the information shared today will help you serve your community better. And now, just a few announcements before we begin the presentation. So the information contained in this presentation is not a substitute for medical consultation. A physician should always be consulted for any health problems or medical condition. And on today's agenda, we'll do our project series, our Project Echo series overview. We'll do some introductions. We'll have our presentation, our case study, and then our Q&A forum. So the Rutgers Cancer Institute became a Project Echo hub in 2021. Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide the best practice care for underserved people all over the world. The ECHO model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right place at the right time. And this is done using technology to leverage scarce resources, sharing best practices to reduce disparities, applying case-based learning to master complexity, and evaluating and monitoring outcomes. For more info on Project Echo, go to the echo.unm.edu website. So today we have Ryan Moulton and Joe Bullock. So Ryan is from the Cancer Institute. He works as a community services coordinator for engagement and advocacy. And he's been with the Rutgers Cancer Institute for 4 years. First, starting out as a health educator, focusing primarily on educating community members and healthcare professionals on topics like prostate cancer, genetics and familial risk, and clinical trials and the research process. After moving into his new role as the community services coordinator, he now works very closely with researchers at Rutgers Cancer Institute to coordinate bidirectional community engagement activities, partnering with a close network of community members to lead and facilitate internal programs in an effort to bridge the gap between research and the community. And Joe Bullock is the COO and interim executive director at Man Up to Cancer. And Joe's going to tell you a lot more about himself during his case study, so I don't want to steal his thunder. So I'm going to go off and hand it over to Ryan.
Thank you, Evelyn. I appreciate the introduction. So, hi, everyone. I appreciate you guys coming out today. My name is Ryan Moulton. As Evelyn mentioned, I work as the Community Services Coordinator for Engagement and Advocacy. So today I'm going to be presenting, a curriculum that we built that focuses on cancers that primarily affect men. So we're going to talk a little bit about men's health, some of the main cancers that are specific to men, the ones we see most commonly diagnosed in men as well. And our goal is to give you guys just that baseline education on these different types of cancers, how to detect these cancers, talk a little bit about the benefits of screening for these cancers as well, and then talk a bit about the different signs and symptoms one might see when faced with one of these cancers. So we'll be moving on to the next slide. So quick pre-test for you guys. So this is similar to what we do for most of our echoes, is just a way to test your existing knowledge on the topic. So we've got a couple of questions here for you. Should be seeing the poll up on your screen now. So we'll give you guys a couple of seconds to answer these, and then at the end we'll go over the answers and give you an explanation as to why each one is its respective answer.
Okay, we seem to have leveled off. Let's continue.
All right, thank you very much. All right, so I just want to start with a brief introduction as to some of the things that cause cancer. I'm sure you're all very familiar with what cancer is in general. These are some of the reasons as to why cancer forms in the first place, and then these are also some of the things that can put us at an increased risk for developing cancer. So it includes things like hereditary and familial risks, of course, chemical exposure, specifically UV radiation. We know the relationship between UV exposure and increased risk for skin cancer, specifically, sunlight exposure, tanning beds. There are also certain viral and bacterial infections that are known to cause or increase your risk for developing cancer. Smoking, secondhand smoke, any sort of tobacco use, that also can increase someone's risk for cancer. And then, of course, there are just instances where sometimes the cells in our bodies just don't divide properly the way they're supposed to, which can lead to instances where you have rapid growth and division of these mutated cells. So, in all instances, what causes cancer is, that major driver turning those normal healthy cells in our body into these cancerous cells. And these are all changes that are happening at the genetic level. So there are, two different types of risk factors when we talk about cancer risk, and we kind of split them off into hereditary and sporadic risk factors. Hereditary, like the name suggests, are genetically linked. So these are risk factors that are passed down from your parents. You may pass these down to your children. These are things that you can't prevent. You can't prevent these genetic changes from happening. You can't prevent a child from inheriting these genetic changes, but you're able to kind of better understand what you may be at a higher risk of when it comes to hereditary cancers by undergoing genetic testing or just understanding your family history of cancer. They only count for about 10% of all cancer cases, whereas sporadic risk factors are the ones that make up about 90% of all cancer cases. And these are risk factors that are occurring over the course of someone's life. These are sometimes also called modifiable risk factors because there are some things that we have control over. We have the ability to avoid certain behaviors or change certain behaviors that may be increasing our risk for developing cancer. For example, smoking. No one is born with a nicotine addiction or born smoking, and so that's a behavior that is typically a choice by someone. And so that would be modifiable, meaning, of course, someone can access tobacco cessation resources to quit smoking. A non-modifiable risk factor that we consider sporadic is aging, that the aging process. This is obviously something we're not able to change or slow down, so we consider that to be a non-modifiable risk factor. So this chart up on the screen, this is kind of depicting the most common types of sporadic risk factors, and it's really most likely a combination of these sporadic risk factors that's, the reason someone develops cancer. So oftentimes, you'll hear people saying things like, oh, cancer runs in my family, which is true. That's absolutely true. But like I just mentioned, it's really only a small number of cases where hereditary factors play a major role in driving cancer, only about 10% again. So the cause of cancer is more likely going to be due to sharing some of these different sporadic risk factors, these modifiable risk factors like learned behaviors, instead of the cancer actually being linked to hereditary risk factors. And so what do all these sporadic risk factors have in common? So these are behaviors that are leading to genetic changes happening over time, which eventually will lead to the development of cancer. And this isn't something that's happening overnight, but rather, over the course of several years for these changes to happen. So now moving into the different types of cancers that are either specific to men or commonly affect men. So prostate cancer is probably the one that we're most familiar with when we think about, specific cancers that are specific to men. Prostate cancer is where you have malignant cancerous cells that form in the tissue of the prostate. And if you're not familiar, the prostate is a gland that's part of the male reproductive system. Its main job is to help make part of the fluid that we have in semen. So it's, where it is in the body, it's located just below the bladder and in front of the rectum. And it's not very big. It's normally only about the size of a walnut. So what happens is, again, with prostate cancer, you have these cancerous cells that form in the tissues of the prostate. I'm going to talk a little bit about this later on. Sometimes what happens with the prostate as men get older. It can end up becoming abnormally large, and it can cause symptoms that are similar to prostate cancer, which would be things like difficulty urinating, problems with sexual function. In this case, we actually consider that a benign disease called benign prostatic hyperplasia, and that's something that, again, can mimic the symptoms of prostate cancer. I'll talk a little bit about that later on, and it can sometimes require different treatments like surgery or medications to kind of help mitigate those symptoms. So these figures here are kind of meant to depict the scope of the problem when it comes to prostate cancer. It's a very common type of cancer that we see, especially, compared to some of the other big cancers that we see in our communities. It is the most common non-skin related cancer that's diagnosed in men. In 2023, we saw about 288,300 new cases of prostate cancer in the United States. And we also know that it is the second leading cause of cancer death for men, only behind lung and bronchus cancer. In 2023, there were about 34,700 deaths from prostate cancer in the United States. And then when it comes to the scope of the problem in New Jersey specifically, there is data from the CDC that suggests New Jersey has one of the highest incidence rates of prostate cancer in the United States. We typically see about 147.4 new cases of prostate cancer per 100,000 men. The only state that has a higher incidence rate than us is Connecticut. But there is a silver lining in all of this, although we do have that very high incidence rate of prostate cancer. When we look at mortality rate, specifically for New Jersey, we do see a very low mortality rate compared to other states. We have one of the lowest mortality rates in the entire country from prostate cancer. We have about 16.2 deaths per 100,000 men. New York and Florida are the only ones that have lower death rates than us, but that's a testament to the work being done to diagnose these prostate cancers very early so that they're a lot more treatable. So when it comes to different types of risk factors for prostate cancer, we know about 1 in 8 men will develop prostate cancer. The average age of diagnosis is 67, so it really does primarily affect older men. And although, again, it's not always fatal, most men who have prostate cancer don't ultimately end up dying from it, but rather with it. But again, we see about 34,000 deaths in the United States from prostate cancer each year. Some of the risk factors include older age. The older you get, of course, the likelihood of developing cancer increases. We also have tobacco smoke, having a family history of prostate cancer, so including any brothers, fathers, grandfathers, and uncles that have a history of a prostate cancer diagnosis. And then having a history of genetic syndromes that can include things like the BRCA gene mutation, which is more commonly linked to an increased risk for breast cancer in women. But people sometimes forget that also men can inherit that gene mutation, and it can cause an increased risk for male breast cancer, but also prostate cancer. So when it comes to the signs and symptoms of prostate cancer, it usually causes no symptoms when it's very early stage. And that's why we really encourage cancer screening for prostate cancer, because a lot of times prostate cancers are just identified through routine screening. So a lot of these problems that you're seeing up on the screen are more likely to be caused by things that are not typically prostate cancer, but it's always important, of course, to talk to your doctor if you have any of these symptoms so that you can undergo the specific tests you need to figure out what the cause is. So when you have more far advanced prostate cancer, start thinking about, stage 3, stage 4 metastatic. This is where you have those symptoms that start to appear. This can include problems with urination, having a slow or a weak urinary stream, also urinating very frequently, especially at night, getting up several times throughout the night to go to the bathroom, feeling a burning or a painful sensation while urinating or ejaculating, or having difficulty stopping or starting urination. And then when people have very far advanced prostate cancer, you may also experience blood in the urine, blood in the semen, or the sudden onset of erectile dysfunction, which is when men cannot get or maintain an erection. So again, when you have more far advanced prostate cancer that is potentially started to spread to other parts of the body, this is where you can have symptoms appear that would be indicative of the cancer spreading to other parts of the body. So having pain in different parts of the body, like the spine, the hips, the chest, which could mean that the cancer has started spreading to the nearby bones. Also, someone with far advanced prostate cancer could have weakness or numbness in their legs and their feet, a loss of bladder or bowel control. Most important thing is for all men, if you are concerned about any symptoms, don't ignore them. It could be a sign of prostate cancer, so we really recommend speaking with your doctor about what your symptoms could mean and how you can undergo the proper tests to figure out the root cause. So when it comes to screening, we're going to talk a little bit about the two different types of screening methods for prostate cancer. So we don't really consider these to be routine screening standards for prostate cancer, and I'll talk a little bit about why that is in a bit. But the two most common methods for detecting prostate cancer are the digital rectal exam and the prostate-specific antigen test, or the PSA test for short. PSA is a molecule that's produced by the prostate that just kind of helps it perform its job, again, help make part of the fluid that's found in semen. The PSA, you check that by undergoing a simple blood test. Usually that's done in a doctor's office, in a laboratory. And normally the amount of PSA in a man's blood is low. The threshold is about 4.0 nanograms per milliliter, but there are certain things that can cause these PSA levels to rise. It could be just having an abnormally large prostate. Also, there are different types of infections that can cause PSA levels to go up, inflammation, trauma to the area, and then, of course, prostate cancer as well. So having an elevated level of PSA is not, guaranteed that someone has prostate cancer. And that's kind of why we don't consider it to be a routine screening standard, because it's always going to have to be followed up by a biopsy. And then the other way we detect it is through the digital rectal exam. And so that is where, this is an exam of the rectum. So the doctor would insert a lubricated gloved finger into the lower part of the rectum. They're just going to go in and actually feel the surface of the prostate for any lumps, any abnormalities, anything that might seem unusual. And then again, this is typically done in a doctor's office, and I understand the stigma behind it, and I understand it may be uncomfortable for some men, but it's typically very quick and not very painful. So what do you do if you're a man and you're undergoing your PSA exam, you're getting your PSA levels checked, and you have elevated levels of PSA in your blood? Or what happens if you go and get a digital rectal exam and they find something abnormal? What would be those next steps? So that's where your doctor is going to recommend a diagnostic test, and that's because, again, those exams are not enough for an oncologist or a doctor to guarantee that it's prostate cancer. You're always going to have to follow it with a diagnostic exam and undergo a biopsy. And so there are a few different techniques for how this is done. In the interest of time, I'm not going to go over them. But if you're not familiar, generally speaking, a biopsy, that's where a doctor is going to take a tissue sample from somewhere in the body where they suspect cancer. And they're going to, determine the extent of the disease by examining those cells and those tissue samples under a microscope. And then this is just an image of what it might look like in a, formal setting undergoing a prostate biopsy. So typically a patient's going to be given local anesthesia, or if the patient prefers, they can be put under full anesthesia. Nonetheless, pain is not typically something that a patient should be concerned about. And then they're going to insert an ultrasound guided probe into the rectum and get an image of the prostate, visualize the prostate, and then they're going to insert a needle through that probe and go in and grab tissue samples from different parts of the prostate. You don't want to just get one area of the prostate. You want to make sure that you're covering several different areas. Usually they'll take, several samples so that they can analyze different areas of the prostate. So these are some of the treatment options for prostate cancer. Surprisingly, one of the main treatment options is active surveillance, which is when you're not actually going to get any treatment. And I know that might sound outlandish, but the reason they do active surveillance is because oftentimes when these prostate cancers are diagnosed very early, they don't pose an immediate threat to life. They're very low risk, they're very slow growing, and what it requires is just routine PSA testing, digital rectal exams, or biopsies just to monitor the progression of the disease. Radiation is another option that's pretty commonly used to treat prostate cancer. And then you also have surgery, which is considered the gold standard treatment for men with prostate cancer. And they typically will do this, of course, in a hospital setting with a non-invasive robotic surgery machine. It's typically a same day procedure. So patients are going to go home from the hospital or the same day or immediately the next day. So they call this a prostatectomy, where they're removing all or part of the prostate gland to remove those cancerous tissues from the prostate. And then, of course, there are risks with all surgeries, but patients who undergo a prostatectomy, they typically have very good long-term outcomes and survival. So just real quick about some of the controversy behind PSA testing, and I hate to use the word controversy, but uh, the fact is, PSA testing is really not a perfect test for screening. And again, that's kind of why we don't consider it a routine standard. Uh, I talked a little bit about the other reasons as to why prostate cancer um, or why PSA levels can be risen in a man's blood, how these, the reasons as to why PSA levels rise in a man's blood. There are many other things that can cause elevated levels of PSA besides prostate cancer. It could be, again, that benign prostatic hyperplasia, which is just having an abnormally large prostate. You also have infections, inflammation, trauma to the area. So what happens is this can lead to instances of false positives. So, a man might go into the doctor's office, get their PSA test results, elevated levels, and that would lead to further diagnostic testing, like getting a biopsy done, only to discover that they don't have prostate cancer. And then we also know about 15% of prostate cancers are diagnosed in men that have normal levels of PSA, so less than 4.0 nanograms per milliliter. And so therefore, we have instances where men may go and get a PSA test done that suggests they don't have anything to worry about. They have normal levels of PSA when they, in fact, discover later on that they did maybe have a very slow growing early sign of prostate cancer. So this is known as a false negative. All right. So given all this information, every man should at least at the very least, they should think about whether they should be screened for prostate cancer and just have that conversation with their doctor or with a trusted healthcare professional about whether screening is right for them. So these are the screening recommendations for prostate cancer. So men under 40 are typically not recommended to undergo prostate cancer screening because it's very, very unlikely for a man before the age of 40 to develop prostate cancer. If someone's between 40 and 54 years old and considered average risk and expected to live at least 10 more years, then they typically, again, are not going to recommend screening, but they can use shared decision making. So having that conversation with their doctor about whether screening is right for them. And then between the ages of 40 and 54, if someone's considered higher than average risk of developing prostate cancer, so that would be someone that has a family history of it, so one or more first-degree relatives, like a father or a brother who were diagnosed. Also, African American men are considered high risk for prostate cancer, so they are typically offered, screening or that option to undergo screening starting at the age of 40. And then otherwise, for prostate cancer screening, it's really not recommended until around age 55 to start that routine screening process. So they should discuss prostate cancer screening with their doctor, use that shared decision-making process to discuss whether it's right for them. And then men who don't have any symptoms of prostate cancer and they have a less than 10 to 15-year life expectancy and they're over 70 years of age, typically are not going to be offered testing because they're not likely to benefit from the early detection of low-risk prostate cancer because it's such a slow-growing cancer compared to others. There just wouldn't be enough time if someone has a limited life expectancy for that disease to become life-threatening, and they would oftentimes be more harmed by the treatment of a very low-risk prostate cancer than they would just leaving and monitoring how fast it's growing. All right, and now I know I'm getting close on time, so I want to talk a little bit about some of the other types of cancers that we commonly see in men. Colorectal cancer is a big one. This is, of course, a cancer that can affect the colon or the rectum. So what happens again, similar to prostate cancer, these cancers are starting because um, something's going on in the tissues of that organ. So with prostate cancer, or excuse me, with colorectal cancer, these begin typically from tissue growth that's initially harmless or benign. We call this a polyp. And about 30 to 50% of the human population are going to develop polyps at some point in their lives. So it's very common for someone to have that. So if we don't detect and remove these polyps in a reasonable amount of time, what happens is they can proliferate and promote cancer. And so that would typically take about a decade to occur. And then we know colorectal cancer, it's the third most commonly diagnosed cancer in the United States, and it's also one of the deadliest. It's the second leading cause of cancer death in the United States for both men and women. So this is just a virtual tour of the colon. So this is what it kind of looks like when, a doctor is doing a colonoscopy looking at the inside of the colon. So they're on the lookout for those polyps that you guys might be seeing in the video on the lining of the colon. They kind of look like little small trees that are growing from the tissue of the colon. And this is what can cause colorectal cancer if it's left untreated. All right, a couple risk factors for colorectal cancer, kind of similar to prostate cancer, but there are differences, of course. Increasing age, being over the age of 50, your risk for colon cancer significantly increases, although we are seeing a rise in colorectal cancer in people younger than 50 years old, so that's a cause for concern. We also know that 1 out of every 10 adults that are being diagnosed with colorectal cancer are in their 40s. Again, kind of showing us that there is a reason. That's kind of why they recommended the baseline screening be lowered to age 45 a couple years back. And then there's also some genetic syndromes that can increase your risk for colorectal cancer. Lynch syndrome is one. Um, if you suffer from IBS, inflammatory bowel disease, that can increase your risk for colorectal cancer. It's important to bring that up with your doctor as well if you do suffer from that, because you can usually discuss getting screened at an earlier age. And then finally, having a family history of colorectal cancer, this can also increase your risk of experiencing, colorectal cancer in your lifetime. And then some symptoms, typically with colorectal cancer, it's usually very silent until it's the later stages. So stage 3, 4 is where the cancer has started to really rapidly progress. This is where you typically start to see those symptoms. Some of the most common ones that we see are feeling tired, feeling very fatigued, having changes in your stool. A lot of times what this entails is a narrowing of the stool when a polyp has grown larger and the stool has a hard time squeezing past that polyp. Bloating, having abdominal pain as well. Very late stage colorectal cancer also typically will see patients rapidly losing weight. So when it comes to screening for colorectal cancer, the gold standard is always going to be a colonoscopy. This is again a procedure where you're actually going to go inside of the colon in the rectum. You're going to search for those abnormalities, cancer, polyps, whatever the case is. It is invasive, so sedation will be required depending on the person, but typically patients do go out fully during this procedure. And then another, I'm not going to go through every single one of these, but another common way to screen for colon cancer is the fecal occult blood test, FOBT. This is just checking for the presence of blood in the stool. There are a couple different types of tests out there for this. Cologuard is a big one that I'm sure many of you have heard of, but typically you're always going to have to undergo a colonoscopy if you have a positive FIT test, just to make sure and confirm it's cancer. And then I want to throw in, some information about male breast cancer, although it's not very common. Only about 1% of all breast cancers are happening and diagnosed in men. But in 2024, it was estimated that around 2,800 new cases of invasive breast cancer occurred in men. And we saw about 530 deaths from male breast cancer nationally. So Although it's not common, I think it's important to kind of highlight what's going on. And breast cancer is about 100 times less common in white men than white women. It's about 70 times less common among black men compared to black women. And, the chances of a man getting breast cancer in their lifetime is about 1 in 833. So again, it's really not very common, but just something to be mindful of. And I want to talk a little bit about testicular cancer as well. This is another type of cancer that is specific to males. It's the most commonly diagnosed, or the most commonly it's commonly seen in men that are ages 15 to 40 years old. We see the average age of diagnosis for testicular cancer being 33 years old. About 50, more than 50% of all testicular cancer cases actually are diagnosed in men between 20 and 34. So it's one of those cancers that typically affects men of younger ages. Fortunately for us, it is pretty treatable. It's very treatable, especially when it's found early. And so a man's lifetime risk of dying from testicular cancer is very low. And patients are typically responding very well to treatments once they catch it. And once they're treated, it has about a 95% 5-year survival rate. So that means men who are diagnosed with testicular cancer will still be alive 5 years after diagnosis. So one of the things we want to highlight is recognizing the signs of testicular cancer. Usually you'll have men will experience a painless lump or swelling um, in the testicle. They may feel a feeling of heaviness or aching in the abdomen or the scrotum, or these are typically what the first signs of testicular cancer would be. And this is why we encourage men to do monthly self-exams to check for any abnormalities. So we'll see what that looks like on the next slide. So we recommend all men test their testes every month. This may help you guys, of course, catch testicular cancer early and making it easier to treat. So it's usually recommended that men set aside about 5 minutes during a shower to perform a self-exam. This will help the scrotum and the muscles that hold the testicles relax, and it makes it easier to perform the exam. So the guide up here is showing you guys how to perform a self-exam on a testicle. So you start with gently rolling the testicle between your fingers, feeling up the spermatic cords on the backside of the testicle. You want to look out for any solid lumps, any bumps on the surface of the testicle. Make a note of any changes in size, changes in shape, consistency of the testicle over time. If you're feeling any painful or tender areas while performing a self-exam, this is where we recommend men seek medical advice from a physician. And, I really want to relay this message. A lot of men avoid discussing testicular cancer due to fear, embarrassment, a lack of awareness sometimes, but really staying silent is where serious consequences might arise. So we know that when it's caught early, it's very treatable. But this is when you delay treatment of that, this is where you allow the disease to advance and makes treatment more complex. So our goal is to kind of help normalize these conversations about testicular cancer and men's health in general by kind of promoting awareness of symptoms, encouraging self-exams, because we really want all men, myself included, to feel comfortable and to feel empowered to seek medical advice when they have any concerns about testicular cancer or any other types of cancers or any other health conditions when it comes to that. And then real quick, again, I know I'm getting close on time. Smoking, we just wanted to bring this up. It's the leading cause of cancer in the United States, not just lung cancer, all different types of cancers. Being exposed to firsthand and secondhand smoke, this can increase your risk of cancer. So these are some of the cancers that smoking is linked to. It's also linked to several other, cancers, not just lung, bladder, cervical, kidney, mouth, pancreatic, stomach, throat cancers. It has the greatest impact on the cancer trajectory. And when you smoke, you're not only affecting your own cancer risk, you're also affecting those around you. So we really encourage tobacco cessation for anyone who is a current smoker. These are just some of the toxins that are found in cigarettes and e-cigarettes. So not pretty to look at. And so we want to make sure you guys have the resources you need to undergo tobacco cessation. So just to summarize again, prostate cancer, it's a very common disease. It affects many men of all races. We know that screening with the PSA blood test, the digital rectal exam, these are the best ways we have to detect prostate cancer early, although it will need to be followed up by a biopsy. And then when we discover cancers at an early stage, prostate cancer, other types of cancers like colorectal cancer, testicular cancer, we know it's potentially curable. So it's important that all men, undergo screening, talk to your doctors about getting screened for prostate cancer and other types of cancers, especially if you have family history of these cancers. We really recommend having those conversations as quickly as possible.
We're now going to go into our case study.
Hi, everyone. Thank you for the introduction earlier. My name is Joe Bullock, and I live in Durham, North Carolina. I was diagnosed with stage 3 colorectal cancer at age 50. Um, I want to focus a little bit on this picture here. For one thing, first I want to say that my life has been impacted by cancer screenings. One thing I want to, as far as testicular cancer goes, when I was in my 20s, I had a scare with testicular cancer. I had an undescended testicle. So, if you know a man that has an undescended testicle, you want to let them know that they are at risk to have testicular cancer. As my doctor put it at the time, what you can't see, you can't feel. And so I actually underwent surgery to find that undescended testicle, had an MRI done, and had a biopsy. And luckily, it was not cancer, but I did want to add that to the importance of those screenings. I did go on later in life to care for my father, who had prostate cancer, and was his direct caregiver for the last 2 years of his life. In that process, I started to have symptoms of colorectal cancer. As many of you know, as a caregiver, a lot of times you deny your own health because you're caring for that person. Um, I started developing blood in my stool. I started all the things that Ryan was talking about earlier. One day, my wife just looked at me in the most loving way. She is an RN and said, "Why haven't you gotten your colonoscopy, stupid?" Um, and again, in the most loving way. And I did go in. I suspected it was cancer. And the reason I'm focusing on this picture is this picture was done a month after. Sorry, a month after I was diagnosed. And then 2 weeks before surgery to remove a 10 millimeter tumor that was found in the sigmoid region of my colon. What Ryan showed you earlier, I went through the colonoscopy. They found 3 or 4 precancerous polyps, the way you saw it, along with that 10 millimeter tumor. So, like I said, 2 weeks after this photo was taken, I went in to have that tumor removed. They found during the surgery that I had about 4 lymph nodes that were cancerous. So it put me at stage 3. So I had to undergo 6 months of chemotherapy. So when I look at this picture, you're looking at a man who you would think is sitting there enjoying a 4th of July celebration with his family. And I was wondering if I would be there for them the next year. Sorry. Um, my kids were teenagers at the time. My daughter was in her first year of college. My son was just starting high school. And so they are now 26 and 21. Sorry. Uh, so in that, um, I made the decision after going through what I went through with my dad and my lived experience going through cancer is that I wanted to help start an organization called Man Up to Cancer. I started it with a friend of mine named Trevor Maxwell, who is still battling stage 4 colorectal he was diagnosed age 41. He's now age 49 and doing well on immunotherapy. So this is a little bit of my bio. All of this I experienced. I struggled with isolation during treatment. I obviously had been through what I'd been through with my dad as a caregiver, wondered what my life was going to be like. The turning point for me, honestly, was one day when I was in my oncologist's office and I had gone through, I think, my second round of chemo. And he just walked in the office and he had all these papers and we were getting ready to talk about the road ahead. And he put everything down and he said to me, I told you 4 months ago, I've got this. you need to believe that. We've used the term, but they used the term curable because I was stage 3. There was no genetics involved. So, he was like, I need you to believe this. And because he was concerned that really I was doing things like throwing up my chemo, and I was doing all these things that you can't be doing this. We're going to attack this cancer. And so at that point, he was not just caring for the patient, not just treating the disease, but he was caring for the whole patient. At that point, he suggested that a therapist come in, sit with me, let's talk through things. So I ended up doing therapy for about 6 months, and just talk therapy, really talking about where we were going, how I was feeling. Because I wasn't talking to anyone. I was only talking to my wife, and she really needed me to find someone else to talk to. She's an RN. She deals with patients every day, so she really needed me to have another person to talk with. So, like I said, it's the therapy for 6 months, and that was what I needed. It helped me get through that time period of my life. And in February of 2019, I was declared no evidence of disease at that point. And that's when I kind of made that decision to really start reaching out to other men in my community, understanding that I probably wasn't the only man going through this, and to help start the organization that we have today. You can go to the next slide. So why is this? And male friendships, some key insights is your average man has maybe 2 best friends, maybe 3 close friends. 17% of men report 0 close friends. 1 in 6 men has no one they call a best friend. This really is causing just a lack of male support. Patients talk about being ghosted during treatment, not having the support systems in place, as they go through treatment. The number of men with 6 or more close friendships has dropped 55% since 1990. Even 26% more in recent surveys. 43% still 43% still regularly check in with friends. This is done through Psychology Today magazine. You can go to the next slide. The main issue is men are less likely to seek support. I'm not going to read all of this, but women are 2 to 3 more times likely to seek support than men through accessing counseling, support groups, wellness programs, according to the data across multiple platforms and studies. Men are more likely to experience social isolation during cancer. I know I did, leading to a higher risk of depression, anxiety, substance abuse, and poor medical outcomes. You're not going to go get a screening if you don't feel good about yourself. If you're not thinking about your health, you're not going to go for those screenings. And that's the issue. Women are 3 times more likely to use support services, and that was cited in this in Maggie's Cancer Centers. I do typically find out that when I go to a lot of conferences, even in this meeting today, I have a feeling it's probably mainly women. And that's very much truth. I'll go to men's health conferences, and typically it's 80-20. It's 80% women, 20% men. Men just aren't that involved in their health screenings and caring for themselves in general. You can go to the next. Thank you. So this is just another cited article about a study published in the Supportive Care in Cancer 2015 found that women are significantly more likely to use psychosocial support services, including individual counseling and group of support. Men cite stigma, the desire to handle things on their own, and a lack of tailored services as barriers. The Cancer Council in Australia reports that men account for only about 30% of calls to their cancer helplines, which is very true across the board, even in the States, and support services, despite having similar incidence rates of cancer. You can go to the next one. So this is something that I said to my therapist one time. I said, I isolated, I thought I was protecting people, but really, I was just making it harder for myself. Sorry. And that was really a turning point for me, that I wasn't really helping my family by being isolated. I was just making things harder for them. And that was really a turning point for me. And this is why men do this. We think by isolating and keeping things to ourselves, we're actually protecting the people around us, and we're really not doing that. Really not doing that. You can go to the next slide. So, what needs to change? We don't need men to be less strong. We need to redefine what strength actually looks like. That's why spaces like Man Up to Cancer exist. This just isn't about feelings, it's about outcomes. When men stay silent, it shows up in their bodies, our diagnosis, and sometimes it costs lives. You can go to the next screen. So, so the typical answer that most men make, and I was at the doctor's office the other day. The nurse came in and we did all the weight check and blood pressure, and she asked how I was doing. And of course, I say, I'm fine. That's like the normal response that most men make. Um, so how do we reach the men who say, I'm fine? Don't force it, create space. What works better is creating a space instead of pressure. A lot of men open up because they don't want to be a problem to solve. They just want to be heard without feeling they are failing. Ask simple, direct questions. How are you doing today? What is the hardest part of your week? Really breaking it down to simple, direct questions. Normalizing how hard this is, because men may not open up the first time or the second time, but if you keep showing up, eventually the wall will start coming down. You don't need to break the wall down. You just need to stand there long enough for him to open the door. Which, reflecting back to my case with my oncologist, that was the case. It was about 3 months before I really opened up and looked for support. You can go to the next screen. So this is so the gentlemen in this photo, again, are my six. We talk about 6 men in your lives. Um, I, sorry. Whew. I talk to these 6 men almost every day. They're a part of my life. Sadly, we've lost a couple of them. A gentleman who you had mentioned, male breast cancer, to put a face on that, passed away last year after battling stage 4 male breast cancer for almost 5 years. And he was a part of our crew. We lost him last year as well. So, Man Up to Cancer, as a leading support community for men impacted by cancer in North America, we offer peer-to-peer support, an annual men's retreat, and a chemo care backpack program. Learning opportunities with more than 40 chapters located in the United States and Canada. We are changing the way men what it means to man up. It's not just about being tough. It means having the courage to accept help and knowing we are smarter and stronger as a pack than we are lone wolves. You can go to the next screen. It just highlights some of our programs. So we had over 100 meetups last month where guys just got together and got to go out for coffee or go out for dinner, to have these talks about their lived experience with cancer. These are all available through our website. The men can join at manuptocancer.org to connect with these chapter groups. You can go to the next screen. I know our program here is our chemo care backpack program. So when the gentlemen join to become members, which is completely free on our platform, if they're going through treatment or enduring treatment, they can register to receive one of these backpacks for free if they live in the United States and or Canada. You can go to the next screen. So in our last program, we call it the Gathering of Wolves Retreat. Obviously, you saw that our logo is a wolf pack, and so we have what's called the Gathering of Wolves. It's the largest men's gathering, largest men's cancer retreat that ever assembled. We're expecting about 200 men to attend this retreat in Pennsylvania. It's just like 4 days of summer fun camp where the guys get to hang out, talk to another man who's living the experience with cancer, and just showing up for one another. And information about that retreat is also available on our website. So you can go to the last. I think that's the last one. Yep, that's the last one. So thank you for giving me the opportunity to share my story. Cancer has impacted my life so much so that now I actually work full-time for Man Up to Cancer. And I also work as a patient advocate through multiple organizations supporting patients as they go through cancer. So thank you.
Joe, thank you so much for sharing your story and just, being honest and so vulnerable
Woohoo!
and just, yeah. If anyone has any questions, please feel free to use the chat. I don't know if I saw any come in, but you can also unmute yourself. Wally, did you have any questions?
Oh, I don't want to take over, but I have lots of questions. Hey, Joe, thank you so
Hey,
much for your time today.
you're welcome.
Fellow prostate cancer advocate. I'm really interested in learning more about the retreat. So I'm
Yeah.
going to go to the website and find
Yes.
that out and see if we can register and attend. And
Yes.
wow, I'm so glad that the stars aligned that I could change my schedule to be here with you all today. But thanks so much, Joe, for everything. Really, really appreciate it. Heart to heart.
You're welcome. Thank you. Thank you so much.
Great to see you, Wally. Anyone else have any questions? Any observations? Janet?
Good morning, everyone. Hi, Joe. Great presentation. You're so brave. Really admire you for
Thank you.
really sharing your story. I work at the Rutgers Cancer Institute, but myself, I was a caregiver for my stepmom who had colon
Mhm.
cancer,
Mhm.
and she survived. She had
Mhm.
stage 3, and she really survived that. And also, as you mentioned, great
Yep.
statistics that women really advocate more for themselves
Yep.
than men, or they're more reluctant
Yep.
into going to care. But you were very brave and you have a great family. I really admire that, and stay strong and continue supporting more men that
Will
really
do.
need inspiring stories like yours. Thank
Thank
you.
you so much.
Anyone else? Okay, we'll move on to the post test.
Hmm.
We'll just give everyone a moment to take that. Joe, what do you think while we're doing the post test? What do you think is like the one? I know you highlighted
Well,
a few suggestions or how to get men to open up or more involved, but what do you think is like your one go-to strategy?
well, I know, like I had to mention our chapter groups, but in those chapter groups, some of them are state and regional or provinces in Canada. We do have an AYA chapter for men who have been diagnosed, yeah, as a child all the way up through adult. So if the gentleman had been diagnosed with a childhood cancer, but is between the ages of 18 and 39, we do have an AYA chapter for those men. We also have a Pride chapter, so the LGBTQ community. We also have a chapter for that community. We also have a men of diversity community because within that community, there's a lot of shame being diagnosed with cancer. So those men have a different psychological need, and we hope these chapters would allow support for those specific communities as well.
And that actually was going to be one of my next questions, like the people who identify as men, I guess the
Yes,
LGBT. That's
yes,
wonderful. And I
yes.
see that Matthew has his hand up.
Oh,
Hello. Hello. I I'm a friend of Joe's. I'm also a
yeah,
volunteer for Man Up to Cancer. I wanted to just add because I'm one of the folks that are doing this very same thing, trying to reach men in our communities. Um, Meeting men where they are. So, you can't, it's impossible. I've found, learned by experience, it's impossible to get men to just come out of the woodwork. The waiting rooms where I'm treated at Memorial Sloan Kettering in New Jersey, leaving around cards, walking up to people and just saying, hi, handing them something, look them in the eye and say, if you're interested. That's the only way I've gotten traction meeting people in our local
yeah,
community and trying to get them
yeah,
to engage. It's really, and I've had low success doing it in any other way. So getting local community centers to agree to have this information available where they can see it, where they're there, in the moment thinking about their health. Message boards, web ads, other kind of ways of reaching people we haven't found are effective. It's meeting them where they are
yeah.
in their health journey, in those moments where they're thinking, what am I doing? Or they're going through it and they see, hey, you're not alone. You can reach out. That's the prime opportunity.
Thank you.
Yeah,
Thank
I
you
know
for
one
that.
of the most, I just attended the Oncology Nurses Conference, in San Antonio, Texas this year. And that was probably one of the most impactful. I think I gave out about 5,000 postcards, literally giving bundles of postcards to oncology nurses, because they are the ones that really are the ones on the ground for us, oncology nurses and the oncology social workers. That's another conference we're hoping to attend in the future, because we find those are also, with, as Michael had said, the peer-to-peer, but also those oncology nurses and oncology social workers are also have been a way for us to reach men, because they have direct contact with them.
Right. So it's that in-person contact. And
That
we're
in-
sort of looking at that ourselves for reaching
Yep,
men, going to the parks, maybe being at those pickup games at recreation,
yep,
that sort of thing.
exactly.
Thank you both. So, for our men, for our for our post test, I'm going to go ahead and let Ryan take the lead on that.
Yeah, so just to kind of go over the answers. So for question one, that's actually true. So for like I've mentioned in the beginning of the presentation, New Jersey, we have one of the higher incidence rates of prostate cancer, um, specifically the second highest, but only behind Connecticut. Um, and it's really not clear as to why that is, but just because we have a very high incidence, we're doing a lot of work to catch cancers early, leading to lower mortality rates. With us having one of the lower mortality rates from prostate cancer in the entire country, it's a testament to the hard work being done to catch cancers early. The second question, the answer is true. So over 50% of all testicular cancer cases are diagnosed in men between ages 20 and 34. So it is one of those cancers that typically is affecting men of younger ages. And just to reiterate again, when it's found early, it's a lot more treatable. And then for the third question, the final question, the answer is also true. Of course, smoking cigarettes, using tobacco products, vaping can increase your risk for developing prostate cancer and then other types of cancers as well. So yeah, that's it from us. And again, I just want to special shout out Joe, everyone at Man Up to Cancer. Your testimony, your story is so powerful, and what you do for men in the community is really incredible. And you know, just thank you so much for giving men everywhere a voice that they sometimes forget that they have. So really thank you for being here. Thank you for sharing your story. And, I'm excited to learn a lot more about Man Up to Cancer and the great things you guys are doing to help normalize those conversations and make sure that men have the support they need.
Thank you, everyone. Thank you, Ryan. Thank you, Joe. We put in our evaluation in the chat, our NJ Seed info, who is one of our wonderful partners that helps get screening, especially colorectal and prostate screening. Our Mighty Networks link is in the chat as well. If you have not signed on to Mighty Networks, please do so, because that is how you can access all of the sessions that we've done to date. And then you can get the recordings, the resources, and the PowerPoints in PDF format. And we're taking a break in July, but we will be back in August, and I think it's going to be on lung health. But thank you everyone for joining us again. A special thank you to Joe. Wonderful, wonderful getting this perspective. And I know it resonates with our audience. People want to hear these stories. They want to get a better understanding of how we can help people get screened and then help them in survivorship as well. Thank you, everyone.
Thank you.
Thanks so
Thank
much.
you.
Yeah.
Great presentation. Thanks.
Thank you.